Hello students, in today's video we are going to discuss hyperthyroidism and its treatment. In this video we will first understand what is hyperthyroidism, its signs or manifestations and causes of hyperthyroidism. In addition to this we will discuss treatment modalities of hyperthyroidism, namely thyroid inhibitors, then radioactive iodine 131, then thyroidectomy and symptomatic treatment of hyperthyroidism. Now, as we all know, thyroid gland is a butterfly-shaped endocrine gland located in the neck region. Now, thyroxine and triiodothyronine hormones are secreted by the thyroid gland. Thyroxine consists of 4-iodine and therefore it's popularly known as T4, whereas triiodothyronine consists of 3-iodine and it is known as T3. Thyroxine and triiodothyronine are collectively termed as thyroid hormone. Now, the main function of T3 and T4 is to regulate basal metabolic rate, that is BMR, and are very essential for the growth and development of body. Now look at this figure. It depicts hypothalamic pituitary thyroid axis. Hypothalamus is located at the base of brain. It secretes TRH, thyrotropin releasing hormone. TRH stimulates anterior pituitary to secrete TSH, thyroid stimulating hormone. TSH further stimulates thyroid gland to secrete T4 and T3. Normal thyroid gland produces about 80% T4 and 20% T3. Very important, T4 is largely inactive, whereas T3 is active thyroid hormone. Now, in peripheral tissues like kidney, liver, 1-iodine is removed from T4 by the enzyme deiodinase and inactive T4 is converted to active T3. Now, as per the requirement of body, thyroid hormones are constantly released in the blood by the thyroid gland. But if the thyroid gland becomes overactive and secretes excessive thyroid hormones, then the condition is termed as hyperthyroidism. So, hyperthyroidism is an endocrine disorder where overactive thyroid gland secretes excessive thyroid hormones, namely thyroxine, that is T4, and triiodothyronine, that is T3. Now let's discuss signs or manifestations of hyperthyroidism. Now, as the thyroid hormones regulate basal metabolic rate, that is BMR, BMR increases in hyperthyroidism. Now, excessive rise in BMR causes increased breakdown of calories in the food, causing weight loss and increased appetite. Now, since more calories are burnt, production of heat also increases in hyperthyroidism, and therefore the body tries to cool itself, or the body tries to dissipate heat by producing excessive sweat. So, increased heat causes heat intolerance and excessive sweating. Now, as the thyroid hormone regulates heart rate increases in hyperthyroidism. Now, anxiety, physical restlessness, mental excitability are commonly seen during hyperthyroidism. Now, in addition to this, hyperthyroidism causes hair loss, muscle weakness, increased gastrointestinal motility in hyperthyroidism results in diarrhea. Other common manifestations are menstrual irregularities, then bulging of eyes or protruding eyeball is seen in the Graves' disease. And very important to remember that Graves' disease is the most common cause of hyperthyroidism. And hyperthyroidism is also often associated with the enlargement of thyroid gland. And this enlargement of thyroid gland is termed as goiter. So, these are the common manifestations or signs of hyperthyroidism. Now let's talk about the causes of hyperthyroidism. Main causes of hyperthyroidism are Graves' disease and toxic nodular goiter. Graves' disease is the most common cause of hyperthyroidism and it accounts for 60 to 80% of all hyperthyroid cases. Now, Graves' disease is an autoimmune disease. In this disease, thyroid stimulating antibodies are produced, and these antibodies continuously stimulate thyroid stimulating receptors located on the thyroid gland, and this causes uncontrolled stimulation of thyroid gland and excessive secretion of T3 and T4, resulting in hyperthyroidism. About 30% of the patients with Graves' disease show sign and symptoms of eye disease, that is Graves' ophthalmopathy. So, Graves' disease may be associated with exothalamus. Now, in this condition, there is bulging of eyes, there is protrusion of eyeball, and the eyes seem to be widely open. Upper eyelid does not fold normally, and the patient seems to be staring most of the time. So, in addition to this, it is an hereditary condition and it is usually seen in younger population. Another very important cause of hyperthyroidism is the toxic nodular goiter. Now, goiter, as we know, is the enlargement of thyroid gland, and it is termed as toxic because this goiter produces excessive T3 and T4. Thyroid nodule refers to a lump or the growth of thyroid cells, and this toxic nodular goiter accounts for 50 to 30% of hyperthyroid cases. So, in this disease, nodules cause enlargement of thyroid gland, and these nodules produce excessive T3 and T4. And this toxic nodular goiter can be caused because of high iodine in the diet and also because of drugs like amiodarone. So, these are the two main causes of hyperthyroidism, namely Graves' disease and toxic nodular goiter. Now, let's discuss management of hyperthyroidism. Now, there are three main treatment modalities by which hyperthyroidism is treated. Now, first is the medical therapy, which includes drugs known as thyroid inhibitors. Now, these drugs also include radioactive iodine, that is iodine 131. Then second is the surgery that is a subtotal thyroidectomy. Now, both these treatment modalities, that is thyroid inhibitors and surgery, are the standard treatment of hyperthyroidism, which inhibits synthesis as well as secretion of T3 and T4. Third is the symptomatic therapy. Now, this therapy only controls symptoms of hyperthyroidism. So, now let's classify these three treatment modalities. Now, first class is of thyroid inhibitors. Now, this include four subclasses, namely thionamides, then ionic inhibitors, then iodides, and the fourth is the radioactive iodine. Now, thionamides or antithyroid drugs are the agents that inhibit synthesis of T3 and T4. Now, these are the most commonly prescribed drugs for hyperthyroidism due to Graves' disease. And these thionamides include propyl thiouracil, then carbimazole, then active metabolite of carbimazole, that is the methimazole. Then are the ionic inhibitors. Now, as we all know, iodine is essential for the synthesis of thyroid hormone. These drugs inhibit iodide trapping by the thyroid follicles. That means these drugs inhibit movement of iodide ions from the blood into the thyroid follicles so that synthesis of T3 and T4 does not take place. And these drugs include thiocyanates, perchlorates, nitrates. Now, these drugs are highly toxic and thus they are not used clinically in the treatment of hyperthyroidism. Now, next, thyroid inhibitors are the drugs that inhibit release of T3 and T4 which is synthesized by the thyroid follicles into the circulation. That means these drugs prevent the release of T3 and T4 from the thyroid gland into the blood. Now, as we know, iodine is essential for the synthesis of T3 and T4, but high doses of iodine inhibits synthesis of T3 and T4. Now, drugs in this class are iodine, that is high doses of iodine, then potassium iodide, then iodides of sodium, then organic iodide, etc. Next is radioactive iodine, that is iodine 131. Radioactive iodine is most commonly prescribed in patients with hyperthyroidism due to toxic nodular goiter. Now, in addition to this, if thionamides fail to control hyperthyroidism due to Graves' disease, then as a secondary option, radioactive iodine is also used there. Then hyperthyroidism can also be treated by surgery, where a part of thyroid gland is surgically removed, and therefore the process is called as subtotal thyroidectomy. Now, in addition to these standard treatments, that is the use of thyroid inhibitors and surgery to control hyperthyroidism, another therapy is the symptomatic therapy. Now, here symptoms of hyperthyroidism such as increased heart rate, anxiety, tremor can be controlled by a beta adrenergic blocker like propranolol. Then calcium channel blockers like for example verapamil can also be used as a second line therapy for patients who are beta blocker intolerant or have contraindications to beta blockers, for example asthmatic patients. So now let's discuss each of these modalities for the treatment of hyperthyroidism one by one. Let's first discuss pharmacology of thyroid inhibitors. Now, in order to understand mechanism of action of thionamides and potassium iodides, let's quickly review and revise biosynthesis of T3 and T4. T3 and T4 are synthesized in thyroid follicle. This is a thyroid follicle with peripheral cuboidal cells and a central lumen. The lumen is filled with a sticky fluid that is called as the colloid. Now look at this chart. It shows biosynthesis of T3 and T4. Now this is a zoomed view of thyroid follicle. Now this is a single cuboidal cell and this is the central follicular lumen. Now thyroid follicle is surrounded by the blood capillaries and this is one of the blood capillary. Now TSH, thyroid stimulating hormone, is secreted by anterior pituitary in the blood. TSH binds to its receptors and this causes formation of thyroglobulin. So thyroglobulin is produced in the cuboidal cell and it is termed in short as TG. Now this thyroglobulin consists of tyrosyl residues. Now T3 and T4 are synthesized on these tyrosyl residues. Now thyroglobulin is released from the cuboidal cell into the follicular lumen. Now as we all know, iodine is essential for the synthesis of T3 and T4. Now this sodium iodide transporter transports iodide ions from the blood into the cuboidal cell, and these iodide ions are further transported from these cells into the follicular lumen. Now very important, thyroid peroxidase enzyme oxidizes these iodide ions to iodine, and this is followed by the process of iodination. So there is iodination of tyrosyl residues on thyroglobulin and this forms diiodotyrosine and monoiodotyrosine. Now this is followed by the coupling, again mediated by the thyroid peroxidase enzyme. Now in the process of coupling, two diiodotyrosine couple to form T4 while one diiodotyrosine and one monoiodotyrosine couple to form T3. So T3 and T4 are formed or they are synthesized on the thyroglobulin. Now, from the lumen, this complex of thyroglobulin is transported to the cuboidal cells by the process of endocytosis. This is followed by proteolysis, and T3 and T4, these T3 and T4 are cut or they are cleaved from the thyroglobulin by lysosomal and protease enzymes. And finally, T3 and T4 are secreted in the blood. Another important point, T4, as we have already discussed, is largely inactive, and the enzyme deiodinase removes one iodine from T4 and converts it to the active T3. So, T3 is the active thyroid hormone. So, this is how T4 and T3 are synthesized in the thyroid follicle, and finally they are released in the blood. Now, thionamides like propylthiouracil, methimazole inhibit the enzyme thyroid peroxidase. So, inhibition of this enzyme blocks oxidation of iodide ions to iodine. So, iodine is not formed, and this prevents iodination of tyrosyl residues. So, this inhibits formation of DIT and MIT. Further, inhibition of thyroid peroxidase enzyme also inhibits the process of coupling. Thus, thionamides inhibit synthesis of T3 and T4 on the thyroglobulin. Now, in addition to this, propylthiouracil also inhibits the conversion of inactive T4 to active T3 by inhibiting the enzyme deiodinase. And thus, propylthiouracil has a very fast onset of action. Now, drugs like oral potassium iodide, that is Lugol's iodine, then saturated solution of potassium iodide inhibits the process of endocytosis of this thyroglobulin complex with T3 and T4. So, this prevents the entry of this thyroglobulin complex from the lumen into the cuboidal cell. Now, these iodides also inhibits the process of proteolysis. So, T3 and T4 are neither cut from the thyroglobulin complex nor they are released in the blood. Now, in addition to this, these drugs also decrease vascularity. That means they reduce the flow of blood to the thyroid gland, and therefore they are used before the thyroid surgery, because these drugs reduce the complication of bleeding, and these drugs also reduce the size of thyroid gland. So these are the mechanisms by which thionamides and drugs like potassium iodides reduce the synthesis and release of T3 and T4, and therefore they are useful in the treatment of hyperthyroidism. So by now we have understood the mechanism of action of thionamides and potassium iodides. Now let's understand the mechanism of action of radioactive iodine. Now most commonly used iodine radioisotope is iodine 131. Now radioactive iodine emits both gamma as well as beta rays. Now beta rays are absorbed in the thyroid tissue, and there after absorption they destroy the thyroid tissue. Now carefully selected doses or a carefully selected single oral dose of iodine 131 causes partial ablation or partial destruction of the thyroid tissue. So this partial destruction of thyroid tissue effectively controls hyperthyroidism, but normal required synthesis and secretion of T3 and T4 is not prevented. Only few people require second or third dose of radioactive iodine. Now these gamma rays, they pass through the thyroid tissue and they are detected by a counter, and therefore these gamma rays are used for the diagnostic effect. Now very important to note that it is essential to normalize T3 and T4 levels by other medicines or by the other drugs. Patients should be pre-treated treated to achieve euthyroidism. That means iodine 131 is administered, or the patient is treated with iodine 131 only after euthyroidism is achieved. Then the onset of action. Now, thionamides exhibit slow onset of action, and around 3 to 4 weeks are required to produce the effect. However, as already discussed, propylthiouracil has a fast onset of action as it inhibits peripheral conversion of inactive T4 to active T3. Then potassium iodides, they exhibit rapid onset of action and effect is seen within a week's time. Then radioactive iodine, iodine 131 also has a slow onset of action and effect is seen after around 2 weeks. Now next, talking about the indications. Thionamides are the most commonly prescribed drugs for hyperthyroidism, especially for hyperthyroidism due to Graves' disease. Now, very important, methimazole and carbimazole are preferred over propylthiouracil, as methimazole and carbimazole are less hepatotoxic. Then propylthiouracil is fast acting. It inhibits peripheral conversion of T4 to T3, and therefore propylthiouracil is a first line thionamide used for the management of thyroid storm. Now, thyroid storm is an acute life-threatening complication of hyperthyroidism. It's an emergency that requires immediate treatment. Then thionamides are also used after radioactive iodine treatment, and these drugs are also used before iodine 131 treatment and also preoperatively before thyroidectomy to normalize T3 and T4 levels, because iodine 131 treatment and surgical removal of thyroid gland is performed only when the patient has attained euthyroidism. Then indications of potassium iodide. Now these drugs reduce vascularity of thyroid gland and therefore they reduce blood flow to the thyroid gland, and thus these drugs are used preoperatively. They are used as preoperative treatment before thyroidectomy to reduce the risk of bleeding. And these drugs are also used as adjuvant or add-on therapy for the management of thyroid storm. Then radioactive iodine, iodine 131 is especially useful when hyperthyroidism is due to toxic multinodular goiter, and these are also used in refractory disease, that is hyperthyroidism not responding to other drugs. Now let's discuss special considerations of for each class of drug. Now propylthiouracil is preferred during first trimester of pregnancy, while methimazole and carbimazole are preferred during the second and third trimester of pregnancy. Now, potassium iodides as well as iodine 131 are contraindicated in pregnancy and lactation. Iodine 131 is also contraindicated in children less than 5 years of age, and iodine 131 can exacerbate or worsen Graves' ophthalmopathy. Then adverse effects. Thionamides can cause skin rashes. Agranulocytosis is the most dangerous side effects of thionamides. Now, sore throat, fever, rashes are the symptoms of agranulocytosis. Then thionamides are hepatotoxic, and hepatotoxicity is very common with propylthiouracil, and therefore in most of the indications methimazole and carbimazole are preferred over propylthiouracil. Then potassium iodides. Acute reaction can occur in sensitive individuals, and these drugs can cause irritation of gastric mucosa, and therefore these drugs are used by diluting with the fluid and should also be used along with food. Then chronic overdose of these drugs can cause salivation, rhinorrhea, that is a runny nose, sneezing, and lacrimation. Then iodine 131 is a radioactive iodine. It produces early and late adverse effects. Now, early adverse effects include nausea and vomiting, then transient loss of smell and sensation of taste. Then late adverse effects can cause thyroiditis, that is inflammation of thyroid gland, dry mouth, etc. Now after thionamides, potassium iodides and radioactive iodine, that is iodine 131, let's discuss the role of subtotal thyroidectomy in the management of hyperthyroidism. Now, subtotal thyroidectomy or thyroid surgery is the surgical removal of a part of thyroid gland. Now, aim of surgery is to reduce the increased T3 and T4 synthesis and secretion in the hyperthyroidism. Now, remaining or surviving live portion of the thyroid gland will produce and secrete normal required amount of T3 and T4. Now, very important, surgery should be performed in euthyroid patients. So, euthyroidism or normal T3 and T4 blood levels should be attained by the use of drugs before performing the surgery. Now, indications of thyroid surgery. Now, thyroid surgery is required if the patient has large goiters with obstructive symptoms like, for example, difficulty in swallowing. Then surgery is also required in the cases of confirmed or suspected thyroid malignancy, that is thyroid cancer. Then toxic multinodular goiter, where iodine 131 is not effective or where iodine 131 treatment cannot be given. Then in case hyperthyroidism is associated with coexisting hyperparathyroidism, and if there are contraindications to anti-thyroid drugs, then also surgery can be performed. Onset of action is immediate. Then contraindications. Now, surgery cannot be performed in case of severe comorbidities, like, for example, very high blood pressure, which can cause surgical risk. For example, very high blood pressure can result in hemorrhage. Then pregnancy. During pregnancy also this thyroid surgery is not performed. Then risk of thyroidectomy are, for example, hypothyroidism. Now, sometimes this thyroid surgery can cause permanent hypothyroidism, and there is also a risk of injury to the laryngeal nerve. If the laryngeal nerve is injured, it can cause paralysis of vocal cord, and in some cases, by mistake, parathyroid gland is also removed along with the thyroid gland. So these are the risk of subtotal thyroidectomy. So after the standard treatments, let's discuss about the symptomatic therapy of hyperthyroidism. And now let's discuss symptomatic therapy of hyperthyroidism. Now, first-line drugs that control symptoms of hyperthyroidism are beta-adrenergic blockers, for example, propranolol. Now, propranolol reduces symptoms of hyperthyroidism caused due to sympathetic overactivity, as these drugs block the sympathetic overactivity. So, they are useful in the management of symptoms like rapid heart rate, tremors, agitation, sweating, anxiety, etc. Now, in addition to this, propranolol also reduces peripheral conversion of inactive T4 to T3. So, because of this, propranolol is very fast acting, and it is also preferred in the management of thyroid storm. Now, indications of propranolol. Now, by now we know that thionamides, iodine 131, produce their effect in 2 to 4 weeks. So, these drugs like propranolol are used to control symptoms of hyperthyroidism while awaiting response to thionamide and radioactive iodine. Now, in addition to this, we also know that euthyroidism is required to be attained before thyroid surgery. So, these drugs are used along with iodides for pre-operative preparation before subtotal thyroidectomy. Propranolol is also essential for the management of thyroid storm. Now, in all those conditions where beta blockers are contraindicated, for example, like asthma, second line therapy, that is calcium channel blockers like verapamil and diltiazem are used. So, this is in brief on hyperthyroidism and its management. Please note, information provided in this video is meant only for students for their academic purpose. For clinical use of any of these drugs or for the management of hyperthyroidism, consult your physician. If you find the video useful, kindly like, subscribe and share this video. Thanks for watching this video.